The only thing about swearing, and I support it, is that there's a possibility that patients could be find this
Yeah,
online.
it is possible.
That would not be distinct from their experience of being on
Yeah.
reference name.
Yeah.
We're going to leave that in, that beginning part.
Oh, are we?
We're good.
going.
Good to go. I'm saying we were just recording. I'm leaving it in.
I love this chaos.
Yeah.
All right. Good morning, everyone, and welcome back to PulmPEEPs. We're coming to you directly from ATS in San Diego. I'm so excited to run into you yesterday and actually get to see you in person. How are you doing today?
Good. I'm doing great. This is like my favorite type of direct quote live episode. We are literally sitting around a table in an open atrium looking over the poster barn in San Diego at a conference. This is awesome. My favorite setting for us having to do a PulmPEEPs episode.
Amazing. And I'm so excited for us to be continuing our collaboration with the ATS Critical Care Assembly and be supporting our podcast for you this morning.
Yeah, so today we are going to preview a session that's happening tomorrow. It's care of dying in the ICU, end of life care in 2024 and beyond. It's taking place tomorrow, Tuesday, May 21st, from 9:15 to 10:45 a.m. in the Marriott Marquis Grand Ballroom, 2 to 4, which is right next to the main convention center. And we're joined by two fabulous chairs and members of that symposium, and we're going to sort of preview it for today.
Perfect. First, I'm excited to introduce Dr. Theodore Jack Awashna. Jack is a Bloomberg Distinguished Professor at Johns Hopkins School of Medicine and the Johns Hopkins Bloomberg School of Public Health. Jack is a critical care physician and has a broad focus on research that understands the broader context of critical illness and the long-term impact this has on patients' lives. He is an enormously productive and successful researcher with hundreds of publications in the field of critical care and is a pioneer in the field of ICU survivorship. Jack is a devoted mentor and has received accolades from numerous societies. His office is right down the hall from me. He always stops by and asks if I need anything, as well as a cup of coffee, which I really appreciate. It's a real privilege to have you on the show today, Jack. Welcome to PulmPEEPs.
I'm so grateful for the opportunity to talk with you guys. I'm so grateful for the work you do to make science accessible to so much of ATS membership.
Yeah, thanks for being here. It's a real privilege for us. Next, I'm excited to welcome back our PulmPEEPs veteran, Molly Hayes. I think it's her third episode, or third or fourth, one of the two. Molly is an associate professor of medicine at Beth Israel Deaconess Medical Center and Harvard Medical School. She's the director of the MICU at Beth Israel. She's also the director of external education at the Carl J. Shapiro Institute for Education and Research. She's also the co-founder of the BIDMC Center for Humanizing the ICU, which has a bunch of cool initiatives around the field that we're talking about now. She's been extensively involved with ATS in leadership roles in the Critical Care Assembly and the newly minted Steering Committee on the Advancement of Learning. And it's always funny for me to introduce Molly because I text with her probably 28 times a day with our mutual interests. But welcome back to PulmPEEPs.
Thank you so much. I'm super excited to be here.
Great. And before we dive into content, just our standard reminder that we have to say, this podcast is not meant for specific medical advice. The views we express today are our own and may not reflect those of our employers and certainly not of ATS.
Thanks, Dave. And to start us off, Molly, would love if you could tell us about the motivation behind bringing the session to ATS this year.
Yeah, so this is an area that I've been interested in for a long time, actually. And people who are listening to this probably know that 20% of Americans actually die in our ICUs. And when we think about how they're dying, they're not just coming in and quickly dying. They're actually sort of lingering for a little while and at the end of their lives for a long time. And I've always wondered, like, why do we let this happen? How can we do it better? How can we serve our patients and our families better? And I will say that I had the privilege of sitting down with Jack at the last year's ATS in DC over a cup of coffee. And we sort of talked about this and talked about what can we do to sort of get this out there and, help people sort of understand that this is a challenge that we all face and something that a lot of intensivists are not really taught. So we sort of scratched the idea for this at last year's ATS, if you remember, Jack. And now we're excited to actually be presenting it tomorrow.
Yeah, that's awesome. I feel like a lot of people go into critical care and most people do it have some story of some amazing case where they worked really hard and someone did really well. But in reality, there's also so many patients who die in our ICUs. And actually, it can be like a really rewarding part of your job, but a super challenging part of your job to provide appropriate care and support to them and our families. So cool that you guys are doing this. Jack, I'm hoping you can tell us, for the people listening who may go to your session, what attendees should expect to learn about and to take away from the session.
So as I've been doing this for a few years, it's become
a little routine to be able to provide a great resuscitation. And I think after the last 4 years, all of us know how to do things with vents that maybe we didn't even imagine we'd ever have to do. That prognostication, communication, and palliation of someone who is dying has become, I think, the most technically sophisticated and challenging component of what we do. And we might wish that other people would do it, but it's at the very heart of what we have to be able to do superbly in order to make our job effective and to meet our obligations to our patients. But I think what I also know after the last few years is what we need to do to meet our obligations to make sure our nursing colleagues are able to keep doing their job, to make sure our learners can stay engaged. And it's an extraordinary privilege, as you were saying, Dave. And so I think our goal is to make sure that we can take everybody from wherever they are in that skill set and help them get a little bit better. And so for folks who this is sort of their first component of thinking about, like, wait, shouldn't I just consult palliative care? Wait, I would do some of that myself. We're going to make you better at that. And for folks who think this is some of the hardest stuff they've done and spent 20 years learning from Randy Curtis and learning how to do this really sophisticatedly, we're going to try to make you a little bit better and hopes that we can have some advanced conversations about how we do this in the hard stuff.
I love how you talk about it like a skill set, like a procedure. I mean, it really is. It's certainly the most challenging procedure that I do these days, where like a central line is rote work. And so we should approach it with the same sort of scholastic attention as we do for everything else in the ICU.
I think that's absolutely right. We actually talked at the Fellows Track Symposium about communication being a procedural skill. We wrote a paper a few years ago called The Proceduralization of Communication, and I think really changing people's mindset that this is just as important as putting in a central line. We often like send the intern or the med student go talk to the family while the rest of us senior people are doing the resuscitation, and really it should be the opposite, I think. And I totally agree with what you said, Jack, that this is like such a privilege to do this work, and really sharing that with everyone tomorrow is something I'm really looking forward to.
I love that. And I think to like humanizing in the ICU, and to the comment that Jack just made too, it's really the full spectrum of patient, family, as well as the full ICU staff, which I think y'all both have put up, with support staff all the way, to nursing colleagues, RT, pharmacy, to the physicians and the trainees that are in the room with us. So I love that, and excited to hear more about this tomorrow. And this is going to be a question for both of you, since you both have a large amount of experience in the ICUs and have really helped shape, I know, the way Dave and I think about the full spectrum of patient care. But when you think of the field of critical care, can be lacking in this area specifically. I like to see things a little bit more optimistic. So I guess another way to put a question to you both is, in a less negative way, where do we have the most opportunity to improve in this arena?
Well, there's a lot of things. I guess maybe I'll start, Jack, and then you can add some more. I think communication is a big one. I think a lot of people now are finally being taught communication skills in medical school and in residency. But when I was in medical school and residency, I didn't have a specific communication sort of class. I also really feel strongly that like just the class alone is not enough. We need to be doing like supervised communication encounters. So having like our residents lead it, but being there and then giving them feedback on it and really giving them this real time kind of on the job training. So I think we have a long way to go in communication skills training. And then I think just in general, like humanizing the experience of critical care is so important. That's some of the work we're doing in the Center for Humanizing the ICU, but really ensuring that we are treating the patient as a person and the family, as people that are going through the worst days of their life and potentially losing their loved one. And I think it takes a mindset shift to focus on that, because we often get so caught up in the physiology and giving pressors and doing all the procedures, but taking a step back to saying like, who is this person and how can I help this person and the family get through this horrible time?
Yeah, I mean, I think one of the challenges here is, as Gordon Rubenfeld has joked, when you've seen one ICU, you've seen one ICU, that there's enormous heterogeneity across ICUs and across practitioners in how good we are at this and how central we see this is to our work, right? There are some brilliant colleagues who think that this is a thing that they can successfully consult palliative care and largely rely on one of their other colleagues to do. There are others of us who would never do that, right? And feel like this is a thing that they should do themselves, and honestly are still trying to figure out what the increased availability of palliative care in the ICU, how we do that effectively with a consult service. So I think part of what we need to do is open a set of conversations where we can, frankly and without fairly and without judgment, still help people advance along, as Molly would say, their procedural skills, expertise in this. Because I think there's both some first order stories that for some ICUs are exactly the story we need to tell, right? Too many people are dying with care that they don't want and are dying suffering. But we also know, and certainly I have witnessed, that there are folks who can sit uncomfortably with prognostic uncertainty, and who I worry, particularly some of our young learners, when they're being pushed in as first years, can actually try to say, well, hospice is a goal I can get. I don't know if I can do the resuscitation, and may in fact actually be pushing people into a more definitive end of life status where honestly our frank prognostic assessment is I don't know. Right, Jackie Cruiser's piece and the committee report from ATS on time limited trials, I think is foundational about sort of building an institutional structure and get a set of procedures, to use Molly's brilliant phrasing, that let us, in some cases where we genuinely don't know, sit in that uncertainty and wait to see what happens, and recognizing that there are different kinds of good deaths. One of the talks I think we're both really excited about is Katie Halshield is going to give a profoundly disquieting talk that comes from 1,500 hours of her just watching in 4 different ICUs how people talk about death and how different clinicians manage their feelings around that, and may in some cases end up foregrounding institutional priorities around what a good death is, uh, to the contrary of individual patient values. And I know I've been there. I've seen those pressures. I don't know that I've always, a younger me has occasionally been sure I knew what someone's good death should be. And I'm not sure I've always listened as well. And so I think, how do we have those set of conversations?
Yeah, that's such great points from both of you, and I'm very much looking forward to Katie's talk. I really hope I'm going to see and hear. She gave us a little preview when we did our last episode with our other symposium, and yeah, I love Molly, your point of viewing people as a person in the ICU. And I think it speaks to what you were saying, Jack, is that a person has a full range of emotions and experience that a person can come with. Not all of them just want someone to say, this must be so hard for you. They could want totally different things. They could want it very straight, very honest. They want it very softened. And so we need to sort of approach them as real, fully developed humans that are having this horrible experience in the ICU. Well, you already gave us a preview, Jack, of one of the specific talks, but Molly, I was hoping you could tell us the rest of the session and who specifically is going to be there and what's going to be covered.
Yeah, great. So yeah, we're really looking forward to this. And I know Jack mentioned Randy Curtis earlier, and I think we are all sort of disciples of Randy Curtis. So I'm excited to sort of share his sort of ethos and his passion, and we should dedicate this symposium to him, actually. So speaking of Randy Curtis, Erin Cross, who trained with him, she's going to be talking to us about communication with patients and families around end of life and serious illness communication. Ton Neville, who actually won the Randy Curtis Humanism Award this year, is going to be presenting on creative compassion and her work on the Three Wishes Project, which we're really excited for people to learn how to implement Three Wishes at their institutions tomorrow. And then we already talked about Katie's talk, and then Anand Iyer from University of Alabama is going to be talking about symptom management at the end of life. And Anand has a great perspective because he is palliative care and pulm critical care. So he sort of lives in that space, and lots of data out there saying that we can be better at this. We should be giving people more boluses and not increasing drips, et cetera. So I think we have a lot of room for improvement in our ICUs sort of across the country, and how we can manage symptoms at the end of life. So I'm really looking forward to that talk too. I don't know, Jack, what else are you looking forward to?
Oh, it's going to be such a great blend. I mean, I think several of these talks are about how do you routinize excellence, right? I think Dr. Neville's brilliant work in particular is about how do you make this what is, in some senses, this deeply humane, incredibly almost artist-like ability to individualize and understand what people's end-of-life experiences could be, and yet find a feasible way to actually land that. And how do you do that on an ongoing basis? And I think that question of how do we integrate this excellence in this into our day-to-day patterns in the same way that we integrate looking at volume loops and looking at resuscitation into our day-to-day components feels so exciting.
Yeah, absolutely.
That sounds like a fantastic panel, and I think really diverse speakers that are going to bring something different and unique from their own experiences and perspective. And as first mentioned earlier, we did recently talk with Katie Hochschild last week about one of her other sessions that she'll be doing at ATS on Wednesday. And we know that for that session, she's going to be talking about inequity and injustice and serious illness and end-of-life care. And we both, I think all of us here sitting today, think this is such an important topic, and learning about it generally requires coming into the session with a reflective and an open attitude as much as possible. Jack and Molly, how do you think providers can best prepare to come into a session about this where they may have a lot of experience and personal approaches or opinions?
That's a great question, Christina. I think of this session, if we manage to pull it off right, is going to be a little bit like coming to a good master class. So in a bad master class, people show up kind of angry that they're not the ones at the center of the stage and want to explain how they would have done that guitar solo. But in several of these cases, you've got John Coltrane on the stage. Like, just hush your darn ego and listen to what the person's doing now. And I think when we're at our best selves, we know how to watch master clinicians and observers do their thing and learn from them, and not spend our time at first saying, oh, here's how I would have done it differently or better, but trying to understand, why did they make the choice that they made there, and how are they thinking about that? And so my hope is that people can come in not with defensiveness, not with hearing what you're doing is wrong, because at some level, what all of us are doing is wrong, right? None of us are as good at this as we should be. This is the hardest thing we do, and it's gotten just harder for the last few years across multiple levels that I suspect Molly and I could spend a whole nother hour talking about. The politicization, the burnout, the sort of the tired. I think you want to come to this with a chance to watch people do something that you do different than you, and hear from them and try to understand what you can take away from them, while not trying to be them, but understand their art.
Yeah, I agree. I think just coming in with sort of an open mind and sort of being present with some discomfort that we're probably going to hear about tomorrow, and sort of like how we sit with that when we're in the unit and sit with families with uncertainty and discomfort, like be prepared to kind of sit with discomfort tomorrow. And just like Jack said, like, we're not the experts. Like, I love this space.
You are literally the expert.
Thank you, Jack. I love this space, and I love to learn in this space, and I learn something every time that I talk about this. So we're also hoping that people will bring their experiences and what they're doing in their ICUs, because we're going to have some time at the end for a discussion, and we can all learn together. But I think just coming in prepared with an open mind and being ready to just be present, and it might be a little bit difficult, and sitting with that discomfort.
Definitely. Working on just listening most of the time, I feel like, is the most important skill that anyone can develop pretty much at any age going through when such experts are talking like you guys.
And I'd actually say it's one of those things that ironically gets easier as you get a little farther along, right? I remember being a second year fellow and I'm feeling judged the whole time. And right, I mean, the judgment was all my own Catholic school coming back out. But right, that's sort of okay, watch great people like Molly do what they do, and just is such one of the privileges of being at this stage of my career. When I'm a visiting professor, I try to make sure I always round in the ICUs for a couple hours just to watch other people do their stuff, and do their stuff for long enough that the masks come down and they just run their team, and I get to learn from that. And I think part of what Molly's crafted so beautifully here is a group of clinicians who are and other folks who are truly gifted at this, and trying to get them to kind of open up the box pretty early, and so we can see that. And I think that's going to be a special session.
Yeah, I think so too. For people that can't make the session, Molly, but are still really interested in this and are listening to the podcast and saying, I want to learn more about this, where are there resources that they could go to get some other info?
Yeah, I think the ATS has a lot of resources. So I hope I don't embarrass you, Jack, but I love your paper that I know you're going to talk about tomorrow, is Recognition of the Acutely Dying Patient. And that paper specifically has a lot of sort of strategies to overcome some challenges, especially when you're working with trainees. So I found that paper really helpful because trainees often struggle with prognostication, but we as attendings also struggle with that. So what are some of the challenges? So I think there's a lot of resources, a lot of things that are published from ATS, and then Jack already mentioned the recent guideline on time-limited trials, which is really great to read through that. That's really helpful as well. And then there's other resources out there. You all had Jessica Zitter as on your podcast recently, and she's trying to sort of create this education across the country and trying to help people learn more about end of life and try to sort of prevent this problem of having people just, I think the term she uses is this conveyor belt in the ICU and sort of at the end of life. So those are two great resources, and there's lots of books out there. And Jack, you probably have other recommendations too.
I think there's a component of this that's wholesale, right? And there's a component of it that's retail. And I think a certain piece is have Molly Hayes out to your institution as a visiting professor for a day. And I'm sure her family's just looking at me, shaking their heads as they hear this. Going like, dude, no, she cannot get more frequent flyer time. But in the same way that for a lot of the way we learn advanced procedures is by having expert proceduralists come out, talk through the general case, but then also sit there with your learners and with your folks and talk through what would you do in this case. We've had Molly out a number of times to Hopkins, and every time the first order feedback is bring her back more, right? Get Gordon Rubenfeld down, get Molly down, get some of the other people who we think are really gifted at this, and watch and have them give you feedback. It's incredible, the community of ATS that has evolved around this in contrast to the silences that were present for so long.
I think also just being like comfortable with this being a space that, is a valued space for research, for clinical work. I'll be honest, when I was a fellow, I really wanted to do this work, but didn't want to be like quote unquote Dr. Death, and didn't want to be the person that couldn't take care of a really sick young ARDS patient, but they brought me in to care for someone who was dying. I wanted to really be this like hardcore critical care clinician. And I've learned, and I think we see now in our units, like being a hardcore critical care clinician is taking really good care of patients and families at the end of life. So I think having honest conversations with your sort of ICU group, and not just the docs, the advanced practice providers, the nurses, the unit coordinators, the trainees, like literally everyone in your ICU, because it takes a village to care for these patients well, and having these conversations is so important.
I almost wonder if those two things like go hand in hand. Is that like you are comfortable that you could hit the pavement hard and work really hard and try to save someone who you think could save, but because you have that skill set, you also feel confident saying like that's not going to work in this scenario. And so I really almost feel like those are two sides of the same coin that have been artificially separated in the way we think about medicine in general.
I think we're so afraid of flogging for really good reasons that, like, honestly, sometimes those like 24 hours, everything turns around, right? Like, I agree, but it's your time, but it's like sometimes it doesn't have to be your time,
right? 100%.
And I think one of the other components of being known as somebody who is going to talk to a family and who's not going to let it linger will help get your other folks on the service who are potentially a little tired and a little worried that they're going to end up flogging, right? That they're willing to work, right? That you can get a truly exceptional resuscitation if people know they're not committed to an endless component, but they're doing this hard for 24 hours, and then we're actually going to see if it works or not. And that it can be a way to get harder core resuscitation out of the multidisciplinary team, right? Because in the end, so much of what we do as an attending is support a team in providing great critical care rather than actually provide great critical care ourselves.
Absolutely.
Great. I wish we had more time to be able to talk with you. And I think Furf and I will probably have Molly and Jack return to our show for an entirely different episode because there's so much to offer. But hopefully you got to preview a little bit about a great symposium that's going to be happening this week here at ATS. We usually end with one kind of takeaway, but actually Furf and I want to end the session today with hearing something from each of you that you've loved about the conference so far. Jack.
For me, the ability to be back and sort of restitching together the community that was so formative for me and provided me so much support as I was coming up and that I really missed for a couple years has been beautiful. And the quality of the assistant professor talks and the sophistication with which, in particular, health services research in critical care and end of life has evolved, is just baffling to me. And I'm watching things that I feel like I could never imagine us being a mature enough scientific and clinical community to be able to discuss, and then being discussed in 12-minute moderated panel sessions. It's just beautiful to see how good the young kids are doing the work.
Great. Molly?
I will say, as an educator to my core, it's been so great to be part of the Fellows Track Symposium, which you ran beautifully, Christina, and really seeing those fellows sort of eyes light up when you're talking about things or they're asking these wonderful questions. And then walking through the poster hall, especially yesterday, I did that, and really seeing like trainees, that like a second year medical student blew me away with her presentation of her poster and the quality of the case reports, thanks to Dave, who's leading the subcommittee on education, critical care, and the Critical Care Assembly, is just amazing. And like, that's the future, and that's so fun to see these young kids. I feel like, I know, like, makes me feel old. Presenting this great work, and I think like kudos to ATS for really like highlighting them and like building them up. And I think the change to the case reports has been awesome. So thanks, Dave, for that great work.
Amazing. Irf, what have you loved so far?
Seeing you, Monty. This is the best part. We never get to be in person. It was awesome. And then, people, I will say it's great that people listen to PulmPEEPs. I think we, for full disclosure on the podcast, it takes a lot of our time. We've often talked about, like, should we do this less or should we do it in a different way? And when people come up and say that they like it, that helps us feel good. So that's great. What about you, Christina? You didn't tell us hers.
I think literally, we ran into each other yesterday. We didn't even know we were like across the hall from each other. So I think just running into the hall and hugging you was one of my best things. As Molly said, I think seeing the trainees here and being able to be part of educational initiatives has also been amazing. And just kind of impromptu meetups, as you said. I feel like as we started this, I was like, oh, my contact tour. And Molly's like, oh, do you have? I think I can give you one of mine. So it's like, people help out in more ways than one here at ATS.
Not that we recommend that.
Yeah, right. All like and flaking, and the other ophthalmologists are like, oh my God. That's awesome. Well, thank you all for listening today. Thanks to Jack and Molly for coming on the show. This was a really great discussion. Hopefully we'll have another one. This episode was written, produced, edited by myself and Christina Montemayor. The music's original music by Eric Rogers, and we'll see you for the next one.